Good afternoon. I'm Chris Fanta. It's my pleasure to welcome you to Asthma Grand Rounds, and a special welcome to those who are joining us today by live webcasting. We're delighted to have you join us. And it's an outstanding program that we have coming this afternoon. Dr. Jeffrey Drazen will be joined by his colleagues, Dr. Lisa Hensky, Jay Kim, Jinar Park, and Kaylin Tantasira to discuss with us the influence of mechanical stress on bronchial epithelial function in asthma. And Dr. Drazen, as all of you know and most of the medical world knows, is editor-in-chief of the New England Journal of Medicine. He was a co-founder of our Partners Asthma Center and remains an active member. And he is professor at Harvard Medical School and the Harvard School of Public Health. And we're absolutely delighted to have him here to kick off our afternoon session today. Dr. Drazen.
Thank you, Chris, and good afternoon, everyone. This is actually a work-in-progress seminar. And one of the major reasons for that is that sometimes when you give one of these rounds, you have a complete story. And we have some very exciting observations, and we have some tantalizing data, but we don't have a complete story. So I'll start off the story and then hand off to various people so you can see how it unfolded. And I want to say the current thinking about airway remodeling is the physiological changes that you see in the airway are derived from airway narrowing, and they're narrowed because of primarily immune mechanisms. In fact, in a recent article we published in the New England Journal, this is a simplified version of the immune mechanisms. And what I learned when I studied physics was when you ever have something this complicated, it's probably wrong. It's missing a simplicity of elegance that it should have. So I've been thinking about this for a long time and wondered whether some of the airway remodeling that we see could actually reflect bronchoconstriction. All the clinical data that we have is certainly consistent with that thinking. As I said, the whole idea is that airway remodeling results from inflammatory cells that lead to an injury repair phenotype that causes airways to have the remodeled characteristics, which is a thickening of the epithelium, the deposition of this collagen stripe. There are more mucus cells here and inflammatory cells and greater number of blood vessels in the subepithelial connective tissue. So it was over 2 decades ago that we were looking at pictures like this. So this is from a guinea pig that's been sensitized and then challenged with antigen and undergoes fatal bronchoconstriction. And you can see how air would have a hard time squeezing through that airway. But the thing that caught my attention at that time was if you were an epithelial cell hanging out on in the airway here, what would it feel like? And we were lucky we had a bioengineer that was on sabbatical working with Roger Cam and I named Barry Wiggs. Actually, after the year with us, got out of pulmonary altogether. But he did finite element modeling of this airway and asked ourselves what would be the mechanical pressure that you would feel if you were an epithelial cell here during airway constriction. And so we modeled the airway like this and said, knowing what we know about the characteristics of airway smooth muscle and the characteristics of the various tissues that made up the airway wall, if you were an epithelial cell, what kinds of forces would you feel? So during normal breathing, it's unlikely that you would generate a force of more than 2 or 3 centimeters of water, while with severe bronchoconstriction, our estimates were that this would be 30 to 50 centimeters of water. And that was important for the data you'll see coming, because what we were then able to show was that small pressures did very little while big pressures did a lot. So armed with this understanding, we said, how can we model this? And so I took actually a year in 1992 off, sort of on a semi-sabbatical. People in the division didn't know this, but I stopped doing administrative work for almost 9 months, and nothing happened different. Proves that's something important to know. And I hung out in the lab, and the idea was to grow these airway epithelial cells in an air-liquid interface, and then to take the membrane that they're grown on and fold it in half. And I found that that was really hard to do. And we came up with this idea of compressing cells using pneumatic pressure. So you take airway epithelial cells we were starting with rat cells, easy to get rats, and taking them from rat tracheal cells, but you can do this with human airway epithelial cells too. You grow them first in a liquid culture on a porous membrane, and then you remove the liquid and create an air-liquid interface. And we didn't do this, it was actually originally done by Scott Randell at the University of North Carolina in Rick Boucher's space. And so we learned how to do this, and you create something that looks like an epithelium. In fact, in the pseudo-color image here from immunohistochemistry, staining for MUC5AC, you get mucus, you get cilia, and you're going to see some movies of what these things look like if you were a movie camera staring down on a well. And then we would apply pneumatic pressure by putting air in the top here, and it squeezes the cells down. And when that happened, these are from Barbara Ressler's data that were published now 13 years ago. A number of genes were transduced. EGR1 comes up right away. We chose this because it was activated in vascular epithelium. Endothelin-1 comes up. TGF-beta comes up late. So we were getting transduction like that. So that certainly suggested that mechanical effects could change the inflammatory environment of the airway. We took it a step further by culturing fibroblasts on the base of the well here. And when you did that, in fact, the person responsible for this model, Melody Swartz, was a fellow in the lab. And I like to point out that last year she was named a MacArthur Fellow. And she's been continuing to work on this now in 3 dimensions. She got more interested in cancer than in asthma. But when you do this and look at the liquid here, you found that there was collagenous protein that is secreted into the media. In fact, the collagen's collagen 3, which is the collagen you find in the remodeled airways in those stripes. So this is now, there's no inflammatory cells in this. It's just airway epithelial cells. And when you do it over and over again, over time, you can actually get, this is immunohistochemistry for MUC5AC, you get more goblet cells. So you can create a remodeled airway simply by applying mechanical pressure. So that's our idea. Now, is this all an artifact of in vitro studies? So this is a paper that we published in the New England Journal, and you have to know that I'm the editor of the New England Journal. So this paper came in, and I said, yeah, this is really interesting to me. But it's actually been reasonably cited, so it wasn't the only one. We've had lots of papers with lower citation rates than this one. What these guys did is they took humans with asthma, and they divided them into 4 groups. And one group got allergen, and they were all allergic to things, and so they got bronchoconstriction. The second group got allergen, got methacholine to constrict airways. The third group got methacholine and albuterol, so that the methacholine was there, but the airways didn't constrict. And the fourth group got nothing, was control. And they first did a bronchoscopic biopsy, that they then had these 3 inhalation challenges. They had a second bronchoscopic exam on the 8th day. This shows the changes in FEV1 on one of those challenge days. So nothing happens with the saline. The albuterol plus methacholine patients actually bronchodilate. The patients getting methacholine alone or allergen have a fall in their FEV1. This is what you would expect. And when they did the second biopsies, they found that after methacholine, there was increased amounts of collagen 3. Remember, that's the same collagen that we found in our airway epithelial cell cultures, and they had enhanced PAS staining, so more mucus cells. So this actually happens in humans, asthmatic humans, when subjected to airway constriction. So the idea is that mechanical effects cause injury repair phenotype, which lead to airway remodeling. That's kind of how this picture looks. So with this introduction, how do we get to a remodeled phenotype? I've shown you some phenomenology, but I want to put your mind in how would it feel if you were an airway epithelial cell hanging out in an airway when it started to constrict. We talked about the pressure you'd feel, but I want to know how you get along with your neighbor. There's lots of airway epithelial cells here, and how do they interact with their neighbors? And for that, I'll turn it over to Jay Kim. Jay Kim works in Jeff Fredberg's lab at the Harvard School of Public Health.
Thank you. So now I'm going to change gear a little bit. So I'm going to turn into some physics of cellular motion in human bronchial epithelial cells. So now I want you to imagine you are in a subway train, very crowded, and now you arrived at the station. You want to get out, but I just got a picture from website. So none of them actually are willing to give you a way out. So you're actually stuck. So as people get jammed in this train, cells actually also get jammed in the cellular monolayer. That's what my lab, Fredberg lab, has been observed. So cells can be jammed when they are very crowded or when they are adhesive together. But when they are less crowded or once they lose their cell-cell junction integrity, then they get unjammed. In a similar example, most of you may have experience with coffee beans jammed in a chute, but if you bang it, suddenly they can flow, so they are unjammed. In the same manner, my lab has been observed that cells can be unjammed by shearing or stretching cellular monolayer. So my PI is Dr. Fredberg. He came up with an idea that we all knew that Dr. Drazen and Gina was compressing cells to mimic bronchospasm. What if that compression is actually inducing unjamming of cellular monolayer? We were surprised when we saw the cellular motions after the compression. Now I'm going to show what we observed. So Dr. Drazen introduced an analyzed system of culture of human bronchial epithelial cells. What you're going to see here is movies captured during 150 minutes. It's captured actually on top of the ALI system. So what we will see here is repeated movie in every 5 seconds, I guess. So first, flittering motions are just cilia, and most of them are very quiet. They are quiescent monolayer. So these guys are just like the people in the crowded train. They are very jammed. But once we compress these cells with 30 centimeter water pressure, as Dr. Drazen pointed out, things now change. Let's see that. Now they move like crazy. They are unjammed by this compression. Okay? So one feature of their motion is not just random. They move in persistent way. And to better quantify their motion, we actually mapped speed of cellular motion. So here, blue is no motion, and red is high speed of motion. When we actually quantify a metric of cellular migration, we observed that the increase of signal was about 100-fold. It was not just 2 or 3-fold. So the signal was huge. And now in this map, what your eye tells is actually packs of red, which represent fast-moving group of cells, eddies of cells. And these eddies are very heterogeneous. So that tells us cells are moving somehow locally, collectively. But the distribution of these packs are very heterogeneous. That features are actually the same features observed in inert jamming material like colloid or sand, or even in components in the tube. So we borrowed a metric from this inert jamming material. So now this is the plot of chi4, so-called 4-point susceptibility, which sounds very complicated, and my colleague actually Nader Kasbini and Chen Park is actually sitting down there. He mostly computed this term. I'm not going to cover the details of this mathematics, but if you have faith on me and him, then I'm going to describe what this plot means. So what you see here is red is depicts the motion of 30 centimeter water compressed cells. So the height of this peak represents size of fast-moving eddies. The red packs that I showed in the previous slide. So about 70 cells are actually in those fast-moving eddies. And the location of this peak represents the lifetime of those fast-moving eddies. So this curve actually shows that the size scale and the lifetime of those eddies. So this curve tells us about the heterogeneity and the time scale of this heterogeneity. So compared to this red, which is the cells compressed with 30 centimeter water, any pressure below 30 or baseline cells, they do not exhibit peak until 75 minutes, which means that cellular motion or dynamics in this system are so slow, so they are not exhibiting any peak until 75 minutes. But eventually there will be a peak, maybe a day, a month, or year, we don't know. But this tells us that this red is unjammed versus this blue and the others are so jammed. So in summary of physics part, now human bronchial epithelial cells cultured 15 days on ALI system, they are jammed. But when they are compressed, they are unjammed, and we also call this fluidization because now cells can flow like fluid. So there's a mechanical phase transition from solid-like state to fluid-like state induced by mechanical compression. And even more surprisingly, the behavior we found in this compressed cell, the fluidized state, is actually recapitulating the behavior of asthmatic cells. Now I'm going to pass it on to Gina to show the behavior of asthmatic cells.
Thanks. Okay, I'm Gina Park, and I'm working at Compressive School of Public Health, and I have my tiny delivery lab with a very hard-working postdoc.
Gina, if you'd like to, you can use the podium. They won't shoot you.
Okay. Are you sure?
The other mic.
Okay. I'm afraid as well. Okay.
You don't have to hold it. That's just talk into that podium then.
Well, actually, I prefer to be standing by as well.
Whatever you want.
Yeah. So I'm gonna use this one. Whatever it is. Okay, so I was surprised that all squeezing things started when I was in elementary school. It's like a long time ago. So, okay, Drazen introduced, and previously we showed that the application of compression to the bronchial epithelial cells recapitulate many features of asthmatic airways, including goblet cell hypoplasia and production of inflammatory, angiogenic, and fibrotic mediators from either epithelial cells or the co-cultured fibroblasts. So in here, our new finding here is a striking phase transition from unjammed to unjammed phase of monolayer of epithelial cells, normal epithelial cells after compressions. So next question we had was whether this striking phenomenon could be recapitulated in the asthmatic airways. So the things we can do is whether we can look at intact human airway, but it's not possible, or we can culture cells from asthmatic donors. So we cultured cells from either normal donor and asthmatic donors. And here we have is here we have the representative movies from one normal donor and one asthmatic donors. So this is time-lapse images as Jay showed, and time-lapse images were taken at every 3 minutes for 150 minutes. So I'll play the movies for normal cell first. So you can see the minimized movement, so virtually the monolayer of cells are jammed. And let's look at the cells from asthmatic patient. Can you see this substantial movement of cells? So this was striking to us, but we proved our hypothesis showing that this striking fluidizing phenomenon is recapitulated as found in the normal cell after compression. This is the speed map of cells corresponding movies that you've watched. So the speed was scaling from by color coding from blue to red. So blue represent virtually not moving cells, and red represent fast moving cells. So on the left side with normal donors having almost no movement or close to zero, and on the right side with asthmatic donors you see pack of red cells, which means cells are moving together at much faster speed. The monolayer of asthmatic cells very comparable to a monolayer of cells from normal donors after application of compressive stress. So we also quantified this motion. This is the comparable the image speed maps from normal donors after compressive stress. So as a cell biology, like me, maybe, or most of you, when we look at these images, yeah, they look similar. But there are smart physicists can transfer this image to the number. So we are collaborating with the physicists, and they calculated using variety of metrics. And one of them was the 4-point susceptibility, as Jay explained. So what we have in the graph on the left is showing the cellular motion of cells after cellular motion of cells in 3 normal donors and 3 asthmatic donors. So asthmatic donors in red curve and normal donors in blue curve. So x-axis showing the time window, and y-axis is showing the number of size of fast-moving cells in a pack or like eddy in a group. So in case of 3 asthmatic donors, the number of cells moving in a pack is range between 30 to 90. And the relaxation time is about around 50. So for example, the image of speed map on the right is donor A2, asthmatic donor A2. So for example, donor A2, the number of fast-moving cell size is about 90, and the relaxation time is about 54. So if you can recall the cells after compression, normal cells after compression, the relaxation time was about 45 minutes, and fast-moving cells was about 70 cells. So it's very well recapitulated the feature we've been detected in the normal cells after compression. So we found this striking phenomenon using the normal cells after compression and the baseline of asthmatic cells. So what could be the explanation of these striking changes? So we decided to look at the biochemical changes we've been detected in earlier. So one of the things I found was compressive stress induced the release of tissue factor from epithelial cells in a pressure dependent manner. So tissue factor is a transmembrane protein, So when you think about the transmembrane protein, maybe it's hard to think about how transmembrane protein could be released. But one of the mechanisms we showed was exosome-mediated release of tissue factor. This is the transelectron microscope image of tissue the exosomes isolated from the conditioned media collected from compressed cell. So you can see the vesicles in a diameter range of like 100 nanometer. So exosomes are nano-sized vesicles that are released from a variety of cells upon fusion of multivesicular bodies with the plasma membrane. So you must be curious why I suddenly talk about the exosome. You were talking about the cell mobility, and now we're talking about the exosome. Because the reason is, if you look at the exosome, this is the depicted images of exosomes. When cells release exosome, that containing the RNA, protein, and plasma membrane compartment. So I thought that could be the clue that I can figure out how cells mobile faster after compressions. I'll explain it later. But we also, for example, we detected tissue factor in the exosomal fractions. So in here, in the middle column with red rectangular, is the exosomal fractions isolated using ultracentrifugation. So we can see detected tissue factor by Western blot along with other exosomal markers. Tissue factor was also detected in an exosome on a plasma membrane, on a vesicle, the membrane of vesicle. So the localization was the same as intact cells. So in epithelial cells, adherent junctions and adherent junction proteins very important in regulation of cell-cell interaction. And also the cell-cell interaction affects cell mobility by changing the tension between cells. So I feel like I was lucky enough to have collaboration with Lisa Hansky through Jeff Redberg and Jay. And one of the preliminary data I saw was when they knocked out folliculin in the cell, epithelial cells, the tension between cells got stronger. So I thought maybe that's the clue that I can figure it out. And this is the paper showing, Lisa showed that folliculin play an important role in cell-cell adhesion in the epithelial cells. So I looked at whether folliculin get depleted from epithelial cells by exosome-mediated pathway. The first thing I did was I collected conditioned media from after compressions. So this is the Western blot of folliculin in the conditioned media after compressions. So folliculin was detected in the conditioned media as early as 3 hours and increased up to 24 hours. So maybe my hypothesis was right. So next thing what we did, we used the folliculin knockdown cells, and that was generously provided by Lisa Hansky. And we measured the velocity of cell. So we looked at speed, how fast the cells are moving. So compared to cells transfected with control vectors, when cells transfected with folliculin, cells moving much faster. This was very comparable to what see in the epithelial cells from normal versus asthmatic cells. So asthmatic cells moving much faster as cells transfected with folliculin shRNA. But our overall goal at the end of the day will be if folliculin is really important in asthma biology. So what we did was we used a murine model of asthma. So this is the routinely used protocol in Stephanie Shore's lab in our program, and I got tremendous help from her lab. And after sensitization and challenged with ovalbumin, I collected BAL and count inflammatory cells to make sure mouse get sensitized, challenged well enough. And then also I did Western blot using BAL. So this is the Western blot result of using BAL after sensitized challenged with ovalbumin. So just we will focus on the bottom column showing that folliculin got substantially increased in the BAL collected by 6 times of albumin exposure compared to the control group. So now we sure this striking phase transition occurred in the normal cells after compression and also at the baseline of asthmatic cells. And also the folliculin plays an important role possibly in asthma pathogenesis and this mobile feature of epithelial cells. So we probably want to know more about folliculin. What's the real function of folliculin? What's known about the folliculin? So I'll hand over to Lisa Hansky. Thank you.
Thank you. So I'm super excited to be here, and this is the first time, as far as I know, that Folliculin has been linked to anything to do with asthma, so we're very interested in your feedback. So I'll tell you a little bit about the disease, Birt-Hogg-Debye syndrome, that is associated with germline mutations in the BHD gene, which is the gene that encodes for folliculin. This is a very, very interesting disease. Let me just see if I can figure out the pointer. That's associated with renal cell carcinoma. So it's a germline tumor suppressor gene mutation inherited in an autosomal dominant way, associated with renal cell carcinoma, shown here, cystic lung disease and spontaneous pneumothorax. You can see the cysts here, and very subtle but interesting tumors, often on the forehead, that are derived from hair follicles. So folliculin was only cloned about 10 years ago and has many known functions. We've been quite interested ourselves in how folliculin may be a positive regulator of the mTOR pathway. There are also reports that folliculin regulates TGF-beta signaling, but what I'll talk about in a little bit of depth today is how folliculin interacts with an adherens junction molecule called plakophilin-4, or P0071, to regulate the activity of RhoA and to affect the adhesion between epithelial cells. So we identified this interaction through a yeast-to hybrid screen and showed both at the overexpression and endogenous levels that folliculin interacts with PKP4 or P0071, shown here. So it was previously known that PKP4 is a member of the P120 catenin protein family, which also includes beta-catenin, and other members of this family have previously been shown to regulate the activity of RhoA. So I think the most interesting thing that we found in collaboration with Hayden Huang at Columbia is that cells that lack folliculin, this gene product, adhere more to each other than cells in the wild type state. And one example of that is shown here. These are 293 cells, and this is the control here. They're shown growing in a non-adherent situation, and then they're sheared by pipetting, and the cells readily shear when they have the wild type control. But when folliculin is downregulated, the cells adhere much more strongly to each other in this stress situation, telling us that in the absence of folliculin, epithelial cells adhere to each other more strongly. We've seen this in multiple other cell types. Oh, actually, we also see this with PKP4 downregulation cells, suggesting that this effect of folliculin is indeed PKP4 dependent. We also see changes in RhoA activity, which may be responsible for this enhanced cell-cell adhesion. And these experiments were done by Jim Liao's lab before he left the Brigham, showing that folliculin null cells, in this case kidney cancer cells, have altered levels of phosphorylation products that are downstream of RhoA. When folliculin deficient cells are grown in a 3D culture, we see defects in lumen formation, which again suggests that there's a problem with the polarity of the cells. So you see here actin staining and DAPI staining of control cells. When folliculin is knocked down, they're unable to form this three-dimensional structure, and similarly when plakophilin-4 is knocked down. This is showing beta-catenin staining in these same cell clusters. Interestingly, when we knock down folliculin in the skin of a mouse, we see a phenotype that we also think may be related to enhanced cell-cell adhesion, and that includes unusually wavy fur, changes in the shape of the whiskers, and a dermatitis and keratitis. And under the microscope, you can see an enhanced inflammatory response in these skin lesions, which we think, again, could be related to this enhanced cell-cell adhesion that we predict when the folliculin is downregulated. So we've We suspect that, just as illustrated here, when you downregulate folliculin, you change the balance between cell-cell adhesion and cell matrix adhesion, resulting in this enhanced cell-cell adhesion that we see in those experiments. So we've now looked in a little bit more detail in collaboration with some people who are in the room today, Becky Barron and Carolyn Owen, at what might be going on actually in lung cysts, and is this cell-cell adhesion activity involved there? So we don't see any change in SAEC cells or HBE cells when folliculin is downregulated in terms of proliferation. We do see some signaling changes that might be relevant, including some changes in mTOR activity, but nothing truthfully very striking. We also see some changes in TGF-beta signaling, which have been reported by other groups, but again, in other cell types, but again, in the lung-derived cells, the changes don't seem consistent between HBE cells and SAEC cells. But we do see this enhanced cell-cell adhesion phenotype quite strikingly, both in SAEC cells shown over here and in HBE cells. So in both cases, we see the same thing I showed you before, that when these cells are grown in non-adherent conditions, they adhere to each other more strongly when folliculin is lost, suggesting that folliculin is a positive regulator of cell-cell adhesion. So and we've looked at a variety of other molecules in these cells. For example, these are the HBE cells, showing that there's really no change in the levels of plakophilin 4 or P120 catinin. So these changes must involve a functional change, not a change in the levels of the proteins themselves. So Carolyn Owen helped us look at the mice that lack one copy of the BHD gene to see if there was any evidence of spontaneous airspace enlargement, and in fact there is no change in airspace enlargement, so these mice don't spontaneously develop those cysts that you saw in the human. And Becky has helped us do studies of ventilator-induced lung injury. So we wondered, because of this enhanced cell-cell adhesion, whether the mice would be susceptible to injury that is a result of barotrauma, essentially high-pressure trauma. And these data show that there is a trend toward enhanced tissue elastance, suggesting enhanced lung injury. In the mice, this is showing hours of mechanical ventilation. And we also saw a trend toward increased macrophages in the BAL fluid and decreased IL-6 in the BAL fluid from the mice after mechanical ventilation. Again, I think coming back to this concept that barotrauma or pressure trauma could be one way that these cells are defective. So just to summarize what we know right now about the activities of folliculin in epithelial cells, downregulation of folliculin causes increased cell-cell adhesion and decreases RhoA activity. I showed you the mouse phenotype, which we think might be related to enhanced epithelial cell adhesion. In lung-derived cells, we see enhanced cell-cell adhesion as the most consistent phenotype. I didn't show you this data, but the BHD mice have decreased levels of pro-inflammatory cytokines in their blood at baseline and a trend toward increased lung injury following Vili. I just want to be sure to acknowledge the people who did this work, particularly Damir Habibulin and Doug Medvitz, who are sitting right here, and Becky's lab and Carolyn's lab, and many, many other people who have been curious about how this genetic disease might be informing our knowledge about other cystic lung diseases and perhaps also asthma. So I'll pass it to Keelan.
All right, I'm bringing up the rear here. In terms of final discussion, we wanted to try and bring this full circle back to say, does folliculin have, the gene for folliculin, have any relationship to asthma whatsoever? Obviously, as Lisa said, and to the best of her knowledge, folliculin has not been associated with asthma before, and I actually did a PubMed search, and I can confirm that folliculin has not been associated with asthma before as a gene. So there have been no prior associations. Having said that, I found, in my extensive search, I actually found one maybe mini link to folliculin in the days of linkage studies based on families finding large regions of chromosomes that may be associated with asthma. I found this study that was published about 10 years ago where they looked for effect modification for families that were exposed to passive or environmental tobacco smoke versus not environmental tobacco smoke. And in fact, in the environmental tobacco smoke exposed family, they noticed a change in susceptibility locus around in the area of chromosome 17p. And as it turns out, folliculin itself is mapped to chromosome 17p in that general region. So it certainly is under the linkage peak here, a suggestive linkage peak. And any of you who know anything about linkage peaks know that these are actually millions of megabases wide, so that there are literally thousands of potential genes in that region, and this in no way by itself implicates folliculin. So in order to investigate this, we actually took this back to our childhood asthma management program cohort. For those of you who are not familiar with the CAMP study, it was a randomized controlled clinical trial that was published in the New England Journal in 2000. They followed 1,041 individuals randomized to an inhaled corticosteroid arm versus placebo or an endocrinal treatment arm, and then carefully followed 3 to 4 visits per year for an average follow-up of 4.3 years for all of the individuals, and everybody followed up for at least 4 years. Okay. In order to interrogate folliculin effects, we specifically focused on asthma exacerbations within this asthma cohort, and we defined asthma exacerbations as prednisone bursts, need for prednisone bursts, which were part of the treatment regimen allowed by treating physicians within CAMP. And this is just to show that, as expected, the budesonide group tended to do better than either the indocrinal or placebo groups overall, but yet still a substantial number of individuals by the end of the clinical trial, on the order of about 60% of individuals on budesonide, actually experienced an exacerbation by the end of the clinical trial. Oops. So, our study design involves these CAMP individuals, and in fact, from about 800 of the 1,041 CAMP individuals, we have actually over the years obtained immortalized B cells. And from these immortalized B cells, obviously we can correlate gene expression with clinical response. In this particular study design, we stimulated these cells to look at the effect of inhaled corticosteroids with administered corticosteroids on the cells or sham treatment. For purposes of our discussion today, we're really only going to focus on the sham treatment arm and its association with folliculin exposure. And from these, we have 164 paired subjects that were Caucasian and randomized to the budesonide treatment arm. So these were individuals who we expect to do better clinically, but we know still had a risk for asthma exacerbations. Now, the microarray that we used for this was the Illumina Human Ref-8 array, and that array has 3 folliculin probes. And I'm going to go over those folliculin probes a little bit in the next slide. So this is the folliculin gene up on top here. As mentioned, it maps to chromosome 17p. The reference sequence for the gene has 14 exons. The ATG start site starts on exon number 4, and it is very commonly alternatively spliced, and the alternative splice form has 8 exons. The important thing from our study perspective is that both of these are very commonly expressed. One probe of the 3 Illumina probes maps to the reference sequence, and the other 2 map to this alternatively spliced sequence. The other thing I wanted to mention about folliculin expression is when evaluated and looked across tissues, you can see that folliculin is basically ubiquitously expressed. Basically, every single tissue type is expressed across a wide variety of functional categories. Here are lung cells. Here are the immune cells that would encompass our immortalized B cells as well. Not only is it ubiquitously expressed, but it's actually very similarly expressed across cell types. So our analysis, basically we conducted 2 different analyses, both focused on exacerbations as an outcome. One was just a repeated measures of how many exacerbations did you have over time, and if you had another one, it counted as an additional outcome exposure. So this was our longitudinal analysis of burst. The purpose of this slide was basically to say, here we have the 3 probes, this top one mapped against the reference long isoform sequence, the bottom 2 probes mapped to the shorter alternatively spliced isoform. But regardless of the probe, each of these was actually associated with exacerbations over time, all 3 of them. The negative side for this test statistic basically says that the higher the folliculin exposure, gene expression exposure, the lower your probability or lower possibility of exacerbations. And I think that that's a lot more clearly shown in this Kaplan-Meier curve. For the Kaplan-Meier curve, what we did was we divided folliculin expression in these individuals into quartiles. And here's the lowest quartile of expression in red. The highest quartile of expression is in blue, in dark blue here. And overall, we noted that in the inhaled corticosteroid budesonide arm, about 60% of individuals, or this 0.4 over here, was the average number of exacerbations for that treatment group arm. You can clearly see that those in red, or those with the lowest amount of folliculin exposure, had a higher rate of overall exacerbations over time, whereas those with high levels of folliculin exposure had the lowest rate of overall exacerbations. And in fact, comparing the lowest to the highest quartiles of exposure gave you a hazard ratio or a relative risk of 2.4 compared to from the lowest groups of 2.5 times as likely to have an exacerbation as the people with the highest expression level. So basically, to summarize, folliculin gene expression is actually strongly associated with the increased risk of asthma exacerbations over time, and this occurs despite the presence of what we would nominally call a quote-unquote protective inhaled corticosteroid treatment arm. The interesting thing here is that it doesn't seem that isoforms have a strong influence. There clearly were some minor association differences between the long reference sequence isoform and the alternatively spliced isoforms, but all of them were associated with exacerbations over time. And this analysis, clearly, one of the limitations is that this was conducted in immortalized B cells. However, the fact that the folliculin expression is very similarly and ubiquitously expressed across cell types suggests that this may, in fact, not be a tissue-specific issue. Okay? And so there is an acknowledgement. Certainly, I want to acknowledge specifically Wei Liang Chu, who helped with conducting of these analyses from our end of things. And this is our whole analysis group, including all the speakers today and everybody else who participated in this project. And I think we're going to have a roundtable open availability for questions.
While everyone's sitting down, I'll try to, there's a lot of ups and downs here, so I'll now go from what there's some things that we know. We know that when we look at normal epithelial cells and expose them to compressive stress, they move around more. They move around. Ordinarily, they're hanging out just like people at a tennis match, not bothering each other, and then suddenly something happens. Now, whether it's a break between games, they move in packs. We know the size of these packs is on the order of 50 to 100 cells, and the duration of a pack hanging out together is on the order of 45 to 50 minutes. That's what we find with normal cells exposed. When we look at asthmatic cells without doing anything, they have that phenotype. Something we know. We know that when we use the folliculin short hairpin RNA experiment, we get cell movement that looks that same way. So that's things we know. Now we're going to speculate. Earth, to everyone here, this is speculation. If it were true that there was something about the asthmatic state that removed folliculin from cell surfaces, they would move around more. The phenotype we see could be recapitulated by that. We can't prove that there's causality there. We know the association exists. So we would like to have you ask questions of the group. You've seen the data. We're working on trying to understand this. It's a work in progress. We think it's a really interesting finding. So now it's open for questions. Josh.
So at the risk of taking you on a slight tangent here, I'm curious about the mechanism of the goblet cell transition that you can get in vitro with applying stretch forces, and how that compares with the conventional pathway that involves IL-4 or STAT6. Specifically, is there a role for EGF receptor transactivation in this system, either to explain that phenomenon or to explain some of the signaling changes or the tissue factor induction?
Can you repeat the question for the,
John, could you hear? I'm going to give this one to you to answer. Repeat.
Yeah, actually, we looked at the goblet cell hyperplasia in vitro, and we haven't look at the cells induced goblet cell hyperplasia by mechanical stress with the same observation. And regarding EGF receptor pathway, tissue factor is not downregulated by EGF receptor, but it's associated with the PKC pathway rather. And there is necessarily no direct relationship between tissue factor release or either exosome release with this migration. So we think because we compress the cell, the multiple cellular pathway got activated, including EGF receptor and PKC and other, and that's more stronger than when we activate one specific pathway. So we think that's kind of complicated and multiple pathway get activated by compression.
All right.
So this is really nice work, and it's coming together really nicely. Do we have a sense of what folliculin is doing to these cells? Are there receptors for folliculin on the surface? And secondarily, these packs of 50, do they differ in terms of what their cytokine profile is and what they are producing than the kinds of cells that remain stationary?
Lisa, you want to address the folliculin?
Yes, I think the question of what folliculin might be doing when it's in these exosomes is a great one. And Janab and I were just talking about this, whether the main function of the exosomal secretion could be to deplete intercellular folliculin, or is it having a signaling role by moving to another cell and inducing a response there? And I think we don't know yet. That's a critical question.
And is there a separate folliculin?
No, there's been no previously reported extracellular folliculin role, so this may be a novel finding here.
What I'm thinking about the folliculin migration from one cell to another cell, so if the exosome-mediated pathway is correct, and if we get the exosomes collected from conditioned media after compressions and incubate with the cell without folliculin, probably that should be appeared. So I think that's in the down of the path for us to look at whether that the translocation of folliculin from the one cell to another cell, then we can have better answers. But that's a very good question, an interesting observation we should do.
Becky?
I was going to ask you maybe, can you speculate on the difference between the compressive stress that you use in the cells and what the mechanical stress is that we apply by a ventilator, and how that might be affecting the cells differently, and what the impact may be?
So one of the things that, if you're a normal cell in a ventilator-induced condition, the pressure is dissipated across the pleural surface, not across the airway epithelium. In fact, the transepithelial pressures are quite low because the pressure inside the airway and the pressure outside the airway aren't all that different. This gets back to work that was done at the Harvard School of Public Health in the 60s and 70s. The pressures felt by a normal cell are probably on the order of 2 or 3 centimeters of water, not 30 or 40. So with very high pressures and with areas of closed lung, so now if you close off a region of lung, the airway epithelial cells will feel high pressure, but not as high as you might think, because there's pores of Kohn and secondary pathways to get the pressure outside the airway up higher than it is in the atmosphere. Other questions? So this is a work in progress. We have genetic evidence suggesting there may be a role for folliculin. We have some cell biology suggesting it could fit in. We've got biophysics showing a very interesting phenotype. We haven't quite all tied it together, but it clearly looks like the injury repair phenotype, the one that's consistently seen in asthma by many people, may have a role in how cells move and how they stick together by this previously unrecognized, at least in asthma, molecule folliculin. And we think that by working together, none of this would have happened if it hadn't been for all the people sitting at the table in the labs. And the idea is that we're working together trying to answer a question, and we're being driven by the question rather than being driven by our method. So anybody that wants to come, ask, help, work with us, we'd love to have your help, and maybe in a reasonable period of time, we'll understand this molecule and its role in asthma. Thanks for your attention.